In this episode of Evidence-Based Moment, we are going to look at a dental procedure called biologic shaping. Hello and welcome to another video from the Comprehensive Dentist. My name is Dr. B and you are watching Evidence-Based Moment, a segment of the channel where I read dental literature, sounds fun, huh? And talk about what I have learned. I also want to remind you that there is a link to a handout in the description down below that you will find useful for today's topic, so check that out. There's a lot more information in the handout than I will be covering in this video, so make sure you check out the handout for the full learning experience. In today's evidence-based moment, we look at an article from 2001. Really? Really, Dr. B? An article from 2001? Yes. This is what some would call classic lit. So the article is from the International Journal of Periodontics and Restorative Dentistry. The article is called Root Reshaping, an Integral Component of Periodontal Surgery, written by Dr. Daniel Melker. Prior to reading this article, I have seen many Facebook posts by Dr. Melker about this technique and I wanted to learn more. Dr. Melker was even kind enough to send me some awesome photos of this technique to help illustrate what the article discusses. So I want to say a huge thank you to Dr. Melker for helping me out with this video. So the article from 2001 calls the technique root reshaping. Currently though, in 2020, Dr. Melker now calls the technique biologic shaping. Biologic shaping is an alternative to conventional crown lengthening. Now before I explain what biologic shaping entails, let's talk about a common clinical scenario to frame our thinking. If you do restorative dentistry, you know that sometimes you have to deal with subgingival caries and subgingival margins. When the caries and restoration margins start to go subgingival, it can lead to many problems. As a restorative dentist, you will have a harder time taking impressions and will find it more difficult to bond and cement restorations without possible contamination or leakage from saliva, gingival crevicular fluid, and blood. Not to mention, subgingival margins can cause periodontal inflammation and loss of supporting bone due to what is known as a biologic width invasion. When we talk about biologic width, we are referring to the gingival tissue that is above the alveolar crest to the base of the gingival sulcus. The connective tissue attachment is roughly 1.07 millimeters and the epithelial attachment is 0.97 millimeters for a total biologic width of 2.04 millimeters. Now here's the thing, 2.04 millimeters is like the average measurement for biologic width, but previous studies have demonstrated that the biologic width measurement varies from person to person. This is an important concept to understand, and 2.04 millimeters may be accurate for some, but could be more or less than is found in others. Another thing to note about biologic width is that during the 2017 World Workshop, it was proposed that the term biologic width be changed to supracrestal tissue attachment. It seems like though that term hasn't really took off quite yet, as most people I interact with still use the term biologic width. So for this video, I will use the term biologic width. So if a restoration margin goes subgingival, it may be so deep that it is now within that 2.04 millimeter space occupied by the connective tissue and epithelial attachment. When this invasion of that space occurs, the body wants to maintain that biologic width. The body says, hey, look, I noticed there is this foreign object here. It could be a filling or a crown, but there is this foreign object here and it is in my personal space. That's not going to work. The body wants to maintain that distance between the bone and the restoration for the biologic width. It's kind of like during this whole COVID-19 pandemic, you hear a lot about social distancing. You know, that whole make sure you stay 6 feet away from each other thing? So one way of thinking about biologic width is that the bone around the tooth wants to social distance itself from the restoration. So the body does what the body knows how to do. It creates that space. Inflammation begins and we start to see destruction of the bone and attachment in that area. Now, like anything in dentistry, small things can turn into big problems over time, and a biologic width invasion is no exception. Historically, if a restoration margin is deep subgingival and there's a biologic with invasion, this has been treated by doing crown lengthening surgery. This involves reflecting a full thickness flap and osseous contouring to create a 3 to 4 millimeter distance between the alveolar bone and restoration margin. This 3 to 4 millimeters of space created allows for proper healing and provides a space for the biologic width to reform. Now, this all sounds great, and many times crown lengthening can be completed and be a very viable, good option for the patient. However, sometimes crown lengthening can be problematic. One big issue with crown lengthening has to do with the location of the restoration margin. If there is caries present or if the final restoration margin has not already been identified, then the surgeon performing the crown lengthening procedure is guessing where the margin will be located. Remember, the surgeon has to create 3 to 4 millimeters of space between the bone and the restoration margin. If the location of the margin is unclear, then it will make it difficult to determine if they have created an adequate amount of space. If the restoration margin is unclear, then it could result in the surgeon removing more bone than is necessary because they would rather remove more than not enough. Bone removal is also required for the adjacent teeth next to the tooth requiring crown lengthening because the bone has to flow and mimic the shape of the gingival tissue that lies on top of the bone. And sometimes to create the 3 to 4 millimeter necessary for crown lengthening, too much bone would need to be removed. This much bone removal could compromise the tooth, leading to a furcation, being exposed, or a poor crown to root ratio. So specifically, in teeth that cannot afford to lose more bone, crown lengthening may not be the best option. This is why providers currently recommend extraction of the tooth followed by an implant as the best option. The amount of bone required for crown lengthening is not practical, and if the tooth fails down the road, we now have less bone for an implant as well. Now, if our goal is to save the tooth, is there a better option than crown lengthening in those situations? Now, as I mentioned earlier, biologic shaping is an alternative to conventional crown lengthening. Now, it is not a complete replacement because crown lengthening is still very beneficial for conditions like altered passive eruption or for cosmetic purposes such as aesthetic crown lengthening. Biologic shaping is a technique that involves reshaping the remaining tooth structure. And after the remaining tooth structure is reshaped, frequently very little bone removal is required. And by shaping and smoothing the tooth and root surface, it minimizes plaque buildup and makes it easier for the patient and our wonderful hygienists to clean the tooth as well. Now, biologic shaping is not just a surgery and something that only the periodontist has to worry about. Biologic shaping is a team approach. It is a shared understanding between multiple parties involved in treating the patient. This means that the periodontist, the restorative dentist, and the lab technician all have to understand the goal of treatment and what the end result should look like. Biologic shaping begins with the restorative dentist. Prior to the surgery, all caries and pre-existing restoration should be removed from the tooth. I personally like to call this procedure COAD, or clean out and diagnose. I have dentists consult me all the time on the restorability of a tooth, and many times the answer to their question is COAD. Clean out the caries and existing restorations and see what we have left to work with. Sometimes that is the only practical way to determine restorability. It is in that moment that you can diagnose the tooth as restorable or not restorable. If the tooth is not restorable, biologic shaping is not the appropriate treatment. Crown lengthening is not the appropriate treatment. Extraction is actually the appropriate treatment. This is why it is important for the restorative dentist to see the patient first, and then once you do the COAD procedure and determine that the tooth is restorable, you're now ready to place a new core buildup. Placing a core buildup is another critical step in the biologic shaping technique. When you place the core buildup, now you have a good landmark for the periodontist or the surgeon to visualize during the biologic shaping. They need to know where the core buildup margin ends. Chances are the final restoration, the crown margins is going to be slightly below that core buildup margin. So if they know where the core buildup margin ends, then they can properly determine if enough space between the bone and the margin has been created by biologic shaping. Biologic shaping involves shaping and smoothing the tooth. After the tooth is smoothed and shaped, they can then measure the distance from the core margin to the bone and decide if bone removal is necessary. And here's the cool thing. Most of the time, after the tooth has been shaped and smoothed, you don't need much bone removal at all. Without doing the core first, biologic shaping becomes no better than crown lengthening, because you would be making your surgeon actually guess on how much bone removal is required. So doing the core buildup first is a critical part of this technique. Now, I'm not going to discuss how to do the core buildup in this video, but there is some information in the handout below that can get you thinking and get you started. Dr. Bill Strupp and Dr. Michael Brum have a core buildup protocol that they recommend for this technique, and I included some information about their technique in the handout. They have done many cases with Dr. Melker and have created what they believe is the best protocol for this technique. To learn more from Dr. Melker, Dr. Strupp, and Dr. Brum, I would encourage you to join the Facebook group called Strupp Brum Dental Protocols. I believe you have to be a dentist to get in the group, and you have to request access to the group as well. You can also download their core buildup protocol for free on their website. I will put the link to their site down below. So at this time, let's hop on the computer back here and look at some of the photos that Dr. Melker provided for this video. So here we have multiple teeth in the upper right quadrant requiring replacement. Now, I'm not 100% sure what the exact reason why these restorations require replacement, but I would guess that it has to do with recurrent caries and possibly even some aesthetic reasons as well. As you can see, there are a lot of things going on with the tooth number 3, and this is where the restorative dentist actually started the case. The pre-existing restoration was removed, and underneath we have what looks like some caries. So at this point, you follow your protocols for caries removal. This is the COAD, or clean out and diagnose, part of the whole process. So in the next photo, it looks like the restorative doc used caries indicator to aid in caries removal. I started using caries indicator about 2 years ago, and I actually use it all the time now. You have to know how to use it properly, or you could remove too much tooth structure. If you want to learn more about caries indicator, I would actually encourage you to check out a video I did called 3 Reasons to Use Caries Detector Dies. I will link that video in the description down below. So after caries removal, we can see that there is not much tooth structure left, and you can visualize how the retraction cord is actually lying in the furcation area. Here's an up-close view of the furcation. So we can tell that the existing crown margin is very close to the furcation. Now we know that furcations are hard to keep clean and a common area for plaque accumulation, so this is not ideal at all. The next photo is after the core buildup has been placed and the crown prep has been smoothed. I believe for this buildup a 4th generation bonding agent was used, so this would be like an etch and rinse bonding agent. And they use a self-cure buildup material like Denmat core paste. I know I personally prefer a 4th generation bonding agent for all of the core buildups because it is compatible with all core buildup materials, whereas some of your newer bonding agents may have some incompatibility issues. And even if you use a dual cure buildup material, it is best to allow these materials to self-cure for as long as possible. By doing that, you will have a higher amount of conversion and less polymerization shrinkage of the material. When doing the core in anticipation of biologic shaping, you also want to have the core material reach the outermost aspect of the tooth margin. And during the refinement of the core and the prep, you only minimally prepare the tooth. When the surgeon does the biologic shaping, they actually remove the pre-existing margin that you see here, and we're going to see how that's removed shortly. In the next few pics, we see the other crowns in the quadrant are being removed. And in this pic, we see that all the crowns have been removed. Lots of stuff going on underneath these restorations. You can start to see why some of these crowns need to be replaced. So we're cleaning things out, removing any caries and existing restorations, and placing new core buildups. And you can see how core buildups are really larger than the existing tooth prep. And again, this is important. That core material needs to reach out close to the existing margin. The next two pics show the preps after they have been finished and smoothed. Now these are crown preps, but you will notice that the finish lines are not wide shoulder margins. In fact, if you originally had a wide shoulder margin within the prep, after the crown was removed, the core buildup should fill in some of that shoulder so that you can actually make the margin more conservative. The final finish line we see here is more like a chamfer margin, so very conservative. And here we can see the provisional restorations. So the patient is now ready to be seen by the periodontist or surgeon who will do the biologic shaping. So before the procedure, the periodontist removes the provisional restorations. This gives the surgeon 360-degree access around each tooth for shaping and smoothing of the tooth. Here we see that a split thickness flap has been elevated past the mucogingival junction. A lingual flap has also been elevated. In this view, we can really appreciate how close that original crown margin is to the furcation. And wow, I mean, that is really close. And without this procedure, you would have a margin basically in the furcation if you try to restore the tooth as is. Then you have a plaque buildup in that area because crowns are often over-contoured over the furcation, and you are likely to see some periodontal issues and inflammation arise, and maybe even recurrent caries down the road. So this margin is not ideally placed for this tooth. The next photo is after the biologic shaping is completed. Biologic shaping involves using a coarse diamond burr to remove any irregularities on the root surface. The pre-existing crown margin is smoothed out and it's actually removed. The CEJ is removed as well if it is present. Any ledges over the furcation are removed and the tooth is smoothed out, creating this smooth flowing surface that blends the line angles of the tooth with the furcation area. And then you finish this up with a fine diamond being used to smooth everything out and create that super smooth surface finish that you see here. All right, now look here. I'm going to actually pull up the before biologic shaping photo and the after biologic shaping photo. Now what I want to point out for you to pay special attention to is the core buildup margin on the facial. In the left photo, you can see how close the core buildup is to the furcation and how close the existing crown margin is to the bone. Now, there is no periodontal probe in this photo, but I would venture to say that there's probably roughly about 2 millimeters of space between the existing crown margin, which is where the core buildup margin is located. So 2 millimeters between that and the actual bone. Now, if we were doing conventional crown lengthening, we would have to drop this bone down another millimeter or two, and the furcation would still be a problem and possibly compromise the tooth further. On the right photo, you can see that by shaping the tooth, removing ledges over the furcation, smoothing out any irregularities, and creating this smooth taper, it has actually created more space between the core buildup margin and the bone. You could tell that the previous crown margin is gone. It's been smoothed away basically by this whole smoothing and finishing process. The biologic shaping has actually created more space between the core buildup and the bone by pushing that core buildup coronally through the shaping process. And normally our final crown will be just below the core buildup. So now that the core buildup is higher, we know that the future crown margin will also be higher. Now you may still need to do a little bone removal to create that 3 millimeters between the core buildup margin and the bone, but not too much bone removal at all. It's going to be nothing compared to the amount of bone removal you would have to do if you did a conventional crown lengthening. This is why biologic shaping requires less bone removal. With these teeth being super smooth and tapered, this is why biologic shaping leads to less plaque accumulation. At this point, the patient goes home, has specific home care instructions to keep things clean and tidy, and then at about 4 weeks after the surgery, the provisionals are either remade or relined with the goal of creating 1 millimeter of space between the healing soft tissue and the provisional margin. You want that space between the tissue and the provisional at this point so the tissue can heal without being challenged by the provisional margin and the plaque accumulation and inflammation that can be caused from the provisional margin. And again, there is no margin on the tooth at the 4 weeks appointment. The provisional is there simply to protect the tooth while the tissue continues to heal and while the biologic width basically forms and finalizes the healing of the tissue. In this photo, we are at about 14 weeks post-surgery. The tissue is healed and it looks amazing. In this specific photo, the restoring dentist has placed retraction cord and has prepped a thin chamfer margin near that gingival margin. The chamfer margin is ideally placed supragingival or equigingival in these cases. You will also notice how the tooth above the furcation has been accentuated to follow the outline of that root at the furcation. So you get this barreled kind of effect. Basically, the barreled in furcation is continued to the occlusal surface of the prep. Once the tooth is prepped, PVS impression is taken, and these photos are the final metal ceramic crowns. Now pay special attention to the molars. You will notice how the lab technician actually created that barreled appearance above the furcation. And you see, this is why your lab technician needs to understand the goals you're trying to accomplish here. Your tooth prep had a barreled in furcation, so that was continued to the occlusal surface of the prep. So this means that your final restoration must have the same thing. If a lab tech makes a crown that has a normal, typical crown contour, it's actually going to be over-contoured over the furcation area, and it will become a plaque trap and a difficult area to keep clean for the patient. And we don't want that. So biologic shaping removes those hard to clean areas and minimizes bone removal in the process. For this to work long term, the final restorations must not have hard to clean areas. This barreled in effect in the crown, although it's not the most aesthetic thing, it's actually easier to clean and keep clean, thereby prolonging the life of the tooth and the restoration and preserving that periodontal attachment, especially near the furcation, for years and years to come. Lastly, if you look at these radiographs taken at a 10-year follow-up, you will see that the tooth maintained vitality, so it didn't need a root canal. And you also see that the biologic shaping is actually conservative in regards to the bone. These teeth look no different than any other tooth on a radiograph that has had a crown. So perhaps now you can see how biologic shaping offers some distinct advantages to conventional crown lengthening and helps preserve bone and teeth. Now make no mistake, we just brushed the surface of biologic shaping in this video. Don't expect to learn everything from this video or from joining a Facebook group. My goal with this video was to use the article to introduce you to a technique that may be something you want to learn more about and possibly incorporate into your practice in the future. I want to again say a big thank you to Dr. Melker for providing the photos for this video, and if you would like to learn more about biologic shaping, I would encourage you to check out the textbook Advances in Periodontal Surgery. Dr. Melker wrote an entire chapter on biologic shaping in this text, and it is very helpful and will only further deepen your understanding of this technique. He has a ton of case examples in that chapter, and I promise you will learn a lot about this technique from that textbook. I will place a link down below if you would like to purchase a copy for yourself. Also, Dr. Melker has a website where he has online videos on every aspect of periodontal surgery to include biologic shaping. The only thing he doesn't cover is implants. If you think you would like to start doing biologic shaping in your practice, I highly recommend you check this site out and take some of his online courses, also giving you access to him to ask further questions as needed. I will place the link in the description below. And last, if you would like to learn more about doing stellar core buildups, I would encourage you to check out Dr. Strupp and Dr. Brum's website. They also do seminars and have multiple resources that will make you a better dentist. Well, hopefully you learned something about biologic shaping today. And for more information, make sure you download the free handout in the description below. Hit that like button if you found this information useful, and be on the lookout for more evidence-based moments in the future. Thank you for watching, and I will see you next time.